So thanks to all the audience who follows our broadcast. We're still live on the first day of the 2020 International Web-Based Neurosurgery Congress. Remember, we're streaming on YouTube Live too. We have the honor today of having Dr. Christopher Ogilvy. Dr. Ogilvy is a distinguished neurosurgeon from the Beth Israel Deaconess Medical Center. He is professor of neurosurgery of Harvard Medical School and director of endovascular and operative neurovascular surgery at the Brain Aneurysm Institute. Today, at the IWBNC, Dr. Ogilvy is going to share a lecture on Unruptured Intracranial Aneurysms, Current Perspective. Please type your questions on the Q&A section. We will read them after the end of Dr. Ogilvy's intervention. Welcome, Dr. Ogilvy, and thank you.
David, thanks very much. I really appreciate the invitation for this symposium. I have been following it throughout the day, as you know, and have been incredibly impressed, not only how it's been going, but the quality and of the speakers. I hope I can live up to some of my colleagues who are also friends. The fantastic job they've been doing. Here are the disclosures for this talk. There's really none relative to this talk. I'm a consultant for a small company. I started thought with a couple of patients, but I'll run through this pretty quickly because based on the questions earlier in the day, other speakers, it's a very savvy audience. And many of you hopefully deal with these unruptured aneurysms just as I do every single day. Anyone with a busy neurosurgical, neurovascular practice are seeing a huge number of unruptured aneurysms, and it depends what your criteria are for what you'll see. I have friends and colleagues who sometimes won't see aneurysms above below a certain size or a certain age patient, but as I hope I'll show you, those are issues that are not exactly lines in the sand in terms of treatment versus observation. However, I will tell you that we observe many more patients than we treat as we encounter unruptured aneurysms. And here's just a quick example. I got called almost urgently on a Friday afternoon of a 67-year-old female lawyer who had headaches, had her MRI scan, and this was what it looked like. And as you can see, it looks like there's about a 5 or 6 millimeter basilar tip aneurysm. Well, we got a CT angiogram, and it turned out just to be a widened basilar tip with atretic P1 segments and large posterior communicating arteries, fetal type PCAs, which explained this anomaly. And it really was an anomaly and not an abnormality. And we feel this is just a widened basilar tip, not a true aneurysm, no treatment needed. Here's a very different patient, a 48-year-old woman. She fell down, she hit her head lightly, a small head injury with a mild concussion, big time smoker, a pack of cigarettes a day, and a CT-CTA shows a 6 millimeter basilar tip aneurysm. And here you can see it nestled in the interpeduncular cistern, and on the sagittal view, you can see the aneurysm here. Now, this is a very different situation, and many of you run your practices based on size of aneurysm in terms of risk of potential hemorrhage. However, I hope to make the argument that size is just one factor that influences our judgment in these aneurysms. In fact, this woman being 48 years old and in the posterior circulation having higher risk of rupture, I believe, and here's a CTA reconstruction. You can see it's a fairly nicely demonstrated aneurysm, symmetric of the PCAs. We went ahead and asked these questions, and we do have a weekly neurovascular conference. Our whole team attends it, neurologists, neurosurgeons, radiologists. We ask these questions of every aneurysm, really, based on age of patient, size of aneurysm, location of aneurysm, and what we think the projected risks and benefits of treatment are, which I'll get into in detail in a couple of minutes. Should the aneurysm be treated? And if so, how should the lesion be treated? Well, for the 48-year-old with the basilar tip aneurysm, here's our angiogram. And in the same setting, we didn't do a diagnostic angiogram. We just went ahead with that at the time of treatment. We went ahead with stent-assisted coiling. As you can see here, the ends of the stent-assisted coiling of this basilar tip aneurysm with a Raymond-Roy 1 occlusion of the lesion. So the question comes up for MRIs, CTAs. Once an aneurysm is detected or read on a scan, the immediate question for the physician and for the patient is what to do. And really, the first thing to do is to prove that it's really an aneurysm. As you saw in that first case, it really didn't turn out to be a true saccular aneurysm requiring treatment. And with imaging improving, and this has happened over the last 15 to 20 years, we have to decide what really constitutes an aneurysm. And working with our radiologic colleagues, we've gotten them to use words like outpouching or fullness, because as the imaging's improved, you can see almost every little twist and turn on the vessels, especially in the carotid artery as it enters the skull. As I'll show you, there's a large number of lesions that are called aneurysms that really clinically are probably silent and will remain silent and don't need or require any treatment. Well, if you look at the literature on imaging of unruptured aneurysms, we look to MRI, MRA, CT angiography, and then cerebral angiography. But I'll just talk briefly about MRI, MRA, and CT, CTA, because in an office practice, that's where most of us end up seeing, that's what most patients come with as they enter your office for the first time with an unruptured aneurysm. It's been detected for one reason or another on these images. And so we look to MRI and compare this in the literature that's available to DSA, the digital subtraction angiography. And you can see here an angiogram compared to an MR. And you can come up with sensitivities of 70%, specificities of 100%, and you can see the positive predictive and negative predictive values. This is from one study in 2003. And if you look over the last, really the last 15 years or so, you can see that the sensitivities and specificities for MRI, MRA are reported as quite high. However, in clinical practice, this doesn't always pan out. And I was at a meeting and discussing over coffee with one of my good colleagues, Rafael Tamargo at Hopkins, the issue that we see patients with MR diagnosed aneurysms, and when we chase these aneurysms down, many times they turn out not to be an aneurysm, rather a twist on a vessel, or in a different location than initially thought. So he went back and actually carefully looked at his office data and found that 38% of MRA positive cases showed no aneurysm on DSA. The majority of these were small lesions, often red in the anterior communicating location, and 21% of additional cases showed a discrepancy between the aneurysm location on MRA and DSA, so something to consider. Well, CT angiogram is the other way we look at and diagnose unruptured aneurysms in a less invasive fashion than a true angiogram. And when you look at this, it obviously gives you nice three-dimensional anatomy, especially if you're contemplating surgery. This lays it out nicely in terms of the relationship to the bony anatomy. Here you can see an ICA lesion in a 76-year-old with headaches. And here's the three-dimensional reconstruction, which very nicely shows this lesion. You can see the ophthalmic takeoff. You can see the clinoid. And when we did more anterior clinoid resections for clipping these lesions, this was extremely helpful. With the advent of flow diversion, I must admit, we're treating many more of these lesions with flow diversion and endovascular techniques, but this can also be a useful adjunct to planning your strategy for those types of approaches. If you look at the sensitivity and specificity of CT angiography, and this is for lesions now thought to be down to about 3 millimeters, you can see sensitivities that run quite high and sensitivities that run quite high, as recently as publications up to 2017. Well, here's the real conundrum. This is a little 4 or 5 millimeter MCA aneurysm that I found a number of years ago doing autopsy on a patient who died in a nursing home from pneumonia. She was 86 years old. This never gave her trouble her whole life. She never knew it was there. But obviously, this is what we are discovering now with increased utility of non-invasive imaging around the world. Any time someone hits their head, every time someone has a headache, many times primary care physicians are getting non-invasive images which show these lesions. How common are unruptured aneurysms? I believe this audience is very savvy to these numbers, but the prevalence at autopsy is on the order of 2 to 5%. That estimates out to about 2 to 5 million Americans that have an unruptured cerebral aneurysm. If you look back at the autopsy studies that were published, most of these in Journal of Neurosurgery in the 70s or late 60s, one very heavily quoted paper by McCormick shows that in a population at the University of Iowa, there were a total of 191 aneurysms discovered when they surveyed, I think it was about 800 or 900 patients. But you can see the size of these was fairly small by standards of what we usually use for treating aneurysms. And they found that unruptured aneurysms were smaller by and large than ruptured aneurysms. And here's a different study from Tennessee from 1965. And you can see the distribution of these aneurysms around the circle of Willis. And I will draw your attention to the paraclinoid location. And if you remember how an autopsy is done, is that a knife is inserted at the skull base to cut off the carotid artery. And what we've found is that it cuts it quite high. And in fact, autopsy studies probably way underestimate the number of aneurysms in the paraclinoid location. Whether it be clinically significant or not is another issue, and I'll show you how that panned out in a CTA study we did. And here was the location of a little over 1,000 aneurysms in autopsy studies, and here are the studies that were performed and the authors that performed them in the 60s and 70s. And it shows you the distribution where the majority of these are in the anterior circulation, with about 10 to 15, 20% in the posterior circulation. And this shows a distribution of size by aneurysm in the autopsy in the autopsy studies published. And you can see that the majority of these are small lesions. And we're going to make that point a number of times through this presentation in terms of size versus rupture and that relationship and how solid that relationship is. Well, how's a brain autopsy done? Can aneurysms be missed, as I've alluded to? And of course, we're seeing many more aneurysms in the unruptured state now than we did 30 years ago because of improved imaging modalities. So here is a patient who had a CTA, and this is read as an aneurysm, a tiny little 3 millimeter, 2 millimeter outpouching of the periclinoid location. And here's a side view, which shows when you do an autopsy, you insert a knife, it cuts the artery right about here, and so that any aneurysm below that point might be missed in an autopsy study. So based on this, we did an image-based study, a CT angiogram study, looking at 10 years of CTA data, and we compared this to other available data. It was about a little over 29,000 scans. There are a couple of carotid angiogram papers published, two good ones from Canada, where they looked at all angiograms done for all reasons. These were done before the advent of high-resolution CT and MR, so they give us something to compare it to do. And you can see in our study the reasons for the indications for obtaining the CTAs that we had. Now realize it's in a high-volume neurovascular center, so it's a skewed data to begin with. But we did find in 29,000 scans almost 3,000 aneurysms, so an incidence of 10% of the patients, with the majority of these being unruptured, as in many studies today. You can see 83% were unruptured, and that the majority of these were in females. Again, another finding we're seeing with unruptured populations, both in the office and in national and international studies, about 70% of patients with unruptured aneurysms are women. And there must be some hormonal influence on this. It has not been worked out in detail, but it's a pretty consistent finding for unruptured aneurysms. In our series for ruptured aneurysms, it's more like 60-40, and this was the breakdown of patients in our series looking at the CTA data. Now, here's data that was obtained from two separate studies that are footnoted down in the corner here from Canada in 79 and 83 of angiography done for any reason at two separate institutions. And you can see the distribution of aneurysms. And I'll just point to the intradural internal carotid artery. You can see about 15% of aneurysms in that location. In our CTA data, you can see it's a much higher percent, 38%. So it's picking up a lot more lesions at the skull base than even angiography did when we compared it. And when we looked at our study by size, and remember, most of these are a big majority of these are unruptured, you can see many of these are below 6 millimeters. And we made these cut points because they're similar to the international study of unruptured aneurysms, which I'll go through in a moment. You can see our unruptured aneurysms we discovered were indeed smaller than the ruptured aneurysms, and this was statistically significant just because there were so many aneurysms in the study. But by and large, they were smaller than the ruptured aneurysms. And here's how the size range broke down for ruptured versus unruptured, where you can see for 6 millimeters on the left, with the smaller lesions, the majority were unruptured. And then as you get larger in size, they were ruptured. So this was a retrospective study, a huge selection bias because it was in a big referral center for neurovascular disease. Many of these scans were done for follow-up. When we get into the decision-making for unruptured aneurysms, we have to balance the risk of rupture, that is the natural history risk, versus the treatment-related risk. And this is a real moving target, as I'll show you. And we have some more recent data combining endovascular and surgical management to try to get more accurate numbers on this. In terms of the natural history risk, This is also a number that is evolving as more data is evolving. And I'll review a few pertinent studies which many people use to guide their practice, including the International Study of Unruptured Intracranial Aneurysms, the Japanese study, the UCAS study, some large meta-analysis, as well as the phases and UTAS scores, which are now being used. And I'll detail those briefly, but I think this audience is probably pretty savvy with these studies already. But prior to the international study, there were several studies that all suggested rates of hemorrhage of unruptured aneurysms on the order of 1 to 3% per year. And Dave Weavers in 1984 published sort of a sentinel paper from the Mayo Clinic where he looked at patients where he had 102 lesions followed conservatively under 10 millimeters. And he found that none of those patients bled over 3 years. While in the 54 patients with lesions greater than 10 millimeters, 15 bled with an incredibly high mortality of 14 deaths. And that led him to design and lead the charge to the NIH to construct the International Study of Unruptured Intracranial Aneurysms. And I'm going to detail some of those results briefly, because I think this is a pretty savvy audience. But when we look at decision-making for unruptured aneurysms and balance the risks of natural history versus the treatment-related risks, we will see, as I hope to present to you, that the natural history side of that equation has patient and lesion-specific factors, which include size of lesion, location of lesion, age of patient, that is, what is their life horizon. So if we're looking at a 30-year-old individual, the number of years we have to worry about with whatever percent per year hemorrhage rate exists is much greater than when we're looking at an 85-year-old individual. And then there's other risk factors layered on top of that, which can influence rupture risk, which include smoking, ethnicity, possibly females versus males. And then we balance that against the risk of treatment, where also risks can be stratified based on patient and lesion-specific factors. The age of the patient, the size of the, obviously age influences any treatment of any neurosurgical disease, but in particular aneurysms has been shown by a number of investigators. The size of a lesion, which influences risk of treatment. You've seen some amazing surgeries earlier today, but all of these come with some risk with the larger and giant aneurysms, both endovascularly and surgically. And then other comorbidities that patient may have. Also related to risks of treatment is the fact that we have a moving target with improved technology and techniques as we incorporate endovascular strategies into a day-to-day practice to manage these patients. So in terms of the natural history side of that equation, our understanding of this is becoming more nuanced with time. There are factors that influence the risk of hemorrhage above and beyond just size. And if one looks at the published data on this, the International Study of Unruptured Intracranial Aneurysms, the ISSUA trial, really was published twice, once in the New England Journal of Medicine in '98, and again in the Lancet in 2003, which was further follow-up of the same population of patients. And then there's a meta-analysis in stroke. However, a lot of the patients in this are taken from the ISSUA trial, but I'll mention it because it begins to open the door to stratification of risk of rupture. For the ISSUA trial, when first published in '98, it was really two studies in one. There was the group 1 patients were those with no history of a previous subarachnoid hemorrhage. So they'd be like the patient I showed you when I started my talk. That is the incidental single aneurysm in a patient without previous hemorrhage. And these patients were broken into two groups. And the results were observed if patients were treated versus natural history, that is the patients that were not treated. And every study is flawed. This study was not randomized, and I was part of it and contributed several hundred patients to it. And the decision to treat an aneurysm was made between the patient and the physician based on a number of factors. So if an aneurysm was found and the patient said, I'm just not having treatment regardless of size or location, then we followed that aneurysm. And if they were treated, it was observed how they did with treatment. At the time, most of these patients were treated surgically. A smaller percentage were treated endovascularly, but it was an interval of time when endovascular strategies were just evolving and becoming more widely spread. But be that as it may, the rates of rupture were much lower than had previously been published in other studies. And you can see it was 0.05% per year per lesion smaller than 10 millimeters. And as in other studies, the larger the lesion, the higher the risk of rupture over time. As you get into large and giant lesions, it's quite a significant number. Predictors of rupture were increasing size, location, where they found that the basilar tip, and they included posterior cerebral and posterior communicating aneurysms in the posterior circulation, and found those to be higher risk compared to other locations. The group 2 patients, and you can see there were a little over 700 of them, had a history of a previous subarachnoid hemorrhage where an aneurysm had been treated, and then a second or third aneurysm where that was followed conservatively and not treated. And in those patients, the rates of rupture, or fixed, and if it was repaired, we looked at how patients did with repair. And in these patients, the risk was higher. It was actually 10 times higher than the unruptured patients that were incidental and single, but still low, 0.5% per year. And then you can see the size influence, and with large and giant aneurysms, didn't have enough patients to make a meaningful statement. Well, in the prospective group, this was the results of treatment, and you can see surgery was performed in this number of patients. And the other surprising factor from this study, or not so surprising, is that when patients were called, mini mental status exams were done over the phone as opposed to single surgeons with selection bias and reporting bias. We found that the morbidity for treatment was much higher than had been previously published. And you can see here that at 1 month and 1 year for both groups, the risks fell into the double digits as opposed to low single digits, which previously surgeon had self-reported. So we see here the rupture risk lower, the complication rate of treatment higher. You would expect less aneurysms would have been treated in the unruptured condition. In fact, we looked at one point at a national database, and we found that there was actually an increase and a gradual increase in the total number of unruptured aneurysms being treated over time. Well, the issue of patients were followed for a longer interval, and our group then published a follow-up study of this, which was published in Lancet. And with further follow-up, rates of hemorrhage were higher for lesions under 10 millimeters, both in group 1 and group 2. So the criteria for those who got treated expanded over time. And this is the graph that sometimes patients bring to the office, where this was the follow-up data, that 5-year cumulative risks of rupture. You can see here for lesions smaller than 7 millimeters in group 1, that is single aneurysms, in the anterior circulation, the rupture rate was reported to be 0. And the study was again flawed because there were a fair number of cavernous aneurysms included in that group. And we know cavernous aneurysms have an exceedingly low, if not 0 rate of risk of rupture. There are caveats to that, but it's pretty few. But you can see as size increases, risk of rupture increases. And for the first time, we're now taking this data and starting to stratify it by location between anterior and posterior circulation lesions, where the posterior circulation lesions carried a higher risk of rupture. The other study that was published in 2000 was from Uvela in Scandinavia, where he says the patients are like stones. They stay where they were born for their whole life many times, and if they do move, the healthcare system is such that they can be followed over time. It was a much smaller number of patients, but with a long interval of follow-up. And you can see here that although smaller number of patients, the majority of these were patients that were type 2 in the ISHUA trial, that is, had previous subarachnoid hemorrhage, and then had other lesions that were followed until the aneurysm ruptured or until death. And in this study, the follow-up, the hemorrhage rates were similar to what had been previously published by others, on the order, as you can see, 10.5% at 10 years and 30% at 30 years, with a little over 1% per year hemorrhage rate. He found that younger age, larger size, and patients who were smokers had a higher risk of rupture. So now we see an environmental factor which may influence risk of rupture. And if you look at other studies, that seems to be panning out, that smoking probably increases the risk of an aneurysm rupturing. Well, the Japanese study was published, as you can see here, in the New England Journal. It's been a number of years now, but it was really a reiteration of the ISHUA study, but in a much larger number of patients. Of course, they were all Japanese, but it was a much higher number of patients. You can see that over 6,000 patients were screened, and in final analysis, they had over almost 2,000 for extended follow-up, published in 2012. But what this gave us was a very interesting look at the data, and I apologize, this is a bit busy, but this actually is a very interesting table because it starts to stratify risk of rupture by location in the head and size of aneurysm. And there's enough patients in each cell to make a meaningful statistical statement about lesions that now are 3 to 4 or 5 to 6 millimeters. When we tried to do that with the ISHUA trial, there weren't enough patients in each cell to adequately stratify statistically these risks of rupture. So now we're seeing stratification by size as well as by location. And in this study, for the first time, it was shown statistically that if an aneurysm had a daughter sac or a bleb, that the risk of rupture was higher than if it didn't have a bleb. And I won't drag you through all the data, but this is a very important study, I believe, because it starts to show rupture rates for smaller aneurysms that we are now seeing in the office. And in very young individuals, that can influence the discussion as whether to not a treated aneurysm. In this study, women and patients with hypertension had an increased risk of rupture. Interestingly, prior subarachnoid hemorrhage, smoking history, family history, and the presence of multiple aneurysms were not associated with risk of rupture, as they had been in the ISHUA, and part of those were in the ISHUA trial. Size had a definite influence on risk of rupture, and the anterior communicator and posterior communicating location, but not posterior circulation aneurysms, were at increased risk of rupture. So there are caveats to it. But with this data, we're starting to see stratifications of rupture by size, site, and irregularity of shape. Now, in terms of size of aneurysm, here's a recent patient with a 5 millimeter aneurysm. Here you can see on the middle cerebral artery, small, found on MRI. Here's her CTA, aneurysm shown. It looks regular in size. Long discussion, decided to operate and fix this aneurysm to clip it. And at surgery, we see this very nasty bleb. Now, how do you incorporate that into the general statistics that I've just run? This would fall into the Japanese study into an irregular shaped lesion if you picked it up preoperatively. A number of these aneurysms, we operate based on CT angiography alone if we feel we have high enough definition. And we can discuss that or have questions about that because it's somewhat controversial. How about size of aneurysm versus parent vessel? We talk about size of aneurysm and risk of rupture, but we ask the question, do smaller distal vessels with a smaller diameter artery have an aneurysm that can rupture at a smaller size? And Bob Carter, when we were working together, and I looked at this, when we looked at the epidemiology and size distribution of intracranial aneurysms in our population that we had treated. And you can see it was over, at that point, a little over 1,600 aneurysms that we went through, but we were able to find 58 lesions in the distal circulation in the anterior or middle cerebral artery, as well as in the pica vessel, and looked at those in terms of relationship to other aneurysms in the head, and looked at risk of hemorrhage versus size of lesion and size of parent artery. And sure enough, the smaller an aneurysm was on a more distal vessel seemed to carry with it a higher risk of hemorrhage than that same size aneurysm on a larger vessel. And as you start to think about the hemodynamics, that can indeed make sense. And you can see here that a high percentage of ruptured distal pica and MCA and ACA lesions were small, less than 10, and many less than 5 millimeters. And we used distal aneurysm size as a surrogate marker for smaller parent vessel size and possibly decreased wall thickness, although that is open to conjecture. Another question, do aneurysms change size prior to and after rupture? Very hard data to get your hands on. Here's a 64-year-old woman with a glial tumor, but who also had 3 unruptured aneurysms. She had an MCA, she had an ACOM, and she had another carotid lesion. So this patient needed surgery for her tumor, and at the time we resected the tumor and clipped this middle cerebral aneurysm, did not clip the anterior communicating artery aneurysm, thinking that her life expectancy was not great. However, 8 months after her tumor resection and right clipping of her MCA, she had a hemorrhage from this irregular shaped anterior communicating artery aneurysm. And then we went ahead and repaired that lesion. But it gave us pause to look at what data we had available. And we went back and tried to find all the patients we had where we had pictures before and after hemorrhage and tried to look at the configuration of those aneurysms to see if indeed the aneurysm had shrunk when it ruptured. And by collaborating with the group shown in this slide here, took a number of institutions, but between our institutions, we found 13 patients in such a condition where we had been following them. We knew about the aneurysm beforehand and then followed it after it ruptured. And what we found is in the majority of these, the aneurysm did not shrink after rupture. In fact, in several, it grew or stayed the same size. So it took 7 centers to get these 13 patients, but 6 aneurysms were larger at the time of rupture. 1 aneurysm was slightly smaller, but no aneurysms were significantly smaller. So we did not feel they shrink after rupture. And this is a meta-analysis of rupture rates based on the data I showed you earlier. Most of this comes from the Unruptured Aneurysm trial, but it's an attempt to begin to stratify risk of rupture by site, by size, and in this situation, by whether they were incidental or symptomatic. And it's felt that asymptomatic aneurysms have a much higher risk or a higher risk of rupture than asymptomatic or incidental aneurysms. Now, regarding size, there's a glaring fact that we left unanswered, and that is when patients present with aneurysmal subarachnoid hemorrhage, 80% have lesions less than 10 millimeters, and 50% have lesions smaller than 5 millimeters. So when unruptured lesions are small, they're less likely to bleed based on the natural history data we have at hand. Yet when aneurysms bleed, they're likely to be small. And there's no great resolution of that discussion unless someone in the audience wants to write in an explanation. I have yet, in talking to statisticians and biostatisticians, have a good answer for that. In 2017, there was a nice review of ruptured aneurysms, and they looked at size based on time of study and when it was reported. And you can see the number of studies here and when they were reported in the literature all the way from 1970 up to 2000. Lesions less than 5 millimeters shown here actually changes with time. The location didn't seem to change much. Here's a picture. Here's the graph of location versus rupture of ruptured aneurysms. Here's size versus rupture. And you can see that the number less than 5 millimeters seems to be getting larger over time, so that a greater number of small aneurysms are being observed over time. The question is, should this influence our judgment in the clinic as to recommending surgery or treatment or endovascular treatment for smaller lesions, particularly in younger individuals with a longer life horizon? Well, how about multiple small aneurysms? Here's a 50-year-old woman, strong family history of aneurysms. Here's her cerebral angiogram, and you can see she probably has one, two, three, 4 aneurysms. Well, even if she had 3, the question is, does a patient with 3 unruptured aneurysms have triple the risk of hemorrhage? And most of you probably know that is not the case. The risk is probably increased, but by how much, it's not known. If one has hemorrhaged, if one of those aneurysms has hemorrhaged and the patient had it repaired, they are often extremely motivated to have the other lesions fixed, particularly if they're in other locations on the other side of the head or in the posterior circulation. They're much less apt to say, let's just follow this aneurysm, having lived through a subarachnoid hemorrhage. So remember that 80% of all ruptured aneurysms that present for treatment are smaller than 10 millimeters. And I say, darn it, the office visit for the 5 millimeter unruptured aneurysm just became an hour, because you're trying to explain to patients and their family how, on the one hand, they have a small unruptured aneurysm, which should have a lower risk of hemorrhage, yet when you've just run up from the emergency room looking at almost the same aneurysm that had ruptured, that when aneurysms rupture, they are likely to be small. Well, the phases score is a report which encapsulates a number of factors into the risk of aneurysmal rupture. It's an acronym for population, hypertension, age, size of aneurysm, earlier subarachnoid hemorrhage from another aneurysm, and site of aneurysm. And you can see these factors and the points assigned, and the more points you have, the higher the risk of the 5-year calculated aneurysmal rupture risk. So I think surgeons have used this kind of score mentally for years, but here's a paper that lays it out in very graphic fashion as to how these various factors might influence rupture rate and therefore influence your risk of potential treatment. The UTAS score was a paper written based on sampling a large number of us in terms of showing us cases and trying to decide which of those unruptured aneurysms would be more likely to rupture or less likely to rupture, and therefore more likely to require treatment or less likely. And it was a score that favored treatment or conservative management based on a number of factors. So this gets very complex, but very complete. But I think every physician who treats these lesions has some type of algorithm that they run, which incorporates all of these factors. Now, another factor that can influence aneurysm treatment is the psychology in unruptured aneurysm. There's great anxiety with unruptured aneurysms. There's patient anxiety. We spend many hours counseling patients with tiny lesions, how they don't need treatment. Family history can influence this, while it also may have an impact on actually the natural history where aneurysms can bleed at a smaller size, anyone who's seen their loved one pass out, die, or be maimed by a ruptured aneurysm is much less apt to watch an unruptured aneurysm almost regardless of size. And then there's physician anxiety in our primary care physicians and emergency room physicians, because they learned in med school that aneurysms were dangerous, which is great. That's the message we want to pass on. But they don't know they have much less of an appreciation of the fine nuances of these details we're talking about today in terms of stratification based on all of the risk factors. So modifiers for hemorrhage risk, that is the natural history, include anatomic factors, that's lesion specific, size, location, lobularity, and possibly multiplicity, and then patient specific factors, age, longer life horizon, family history, ethnicity, anxiety, and smoking. Smoking is shown in a number of studies to increase the risk of rupture of an aneurysm. And then there's treatment-related risks of aneurysm. So this is the other side of that scale I showed you early on, where we look at what's the risk of treating an unruptured aneurysm. And the Issuance trial did have a prospective arm, as I showed you, where the overall morbidity and mortality was much higher than had previously been predicted, both for surgical interventions and, in this graph, for endovascular interventions. But realize this complete occlusion rate of 50%, 55%, as well as these risks, are pretty early on in the endovascular experience of treating aneurysms. Remember, GD coils were approved in '93, and this was only an 8 or 10 year interval into that, where the majority of aneurysms were still treated surgically. Endovascular coiling, there was a number of subsequent reports throughout the early 2000s in terms of prospective and retrospective data showing that morbidity and mortality continued to drop over that interval as techniques improved. Bob Carter and I looked at open surgery for unruptured aneurysms in a population of 604 aneurysms we operated on, and many of these would not be operated on today. It was reported in 2003, but I just want to show it to you because I'll compare it to a combined modality therapy in a few minutes. And the distribution of patients in this subpopulation is very similar to a standard aneurysm population of unruptured lesions treated, both in terms of the majority being in the anterior circulation and the size. You can see the distribution of aneurysms we treated, and yes, we did treat some smaller lesions based on some of the other factors I've alluded to. We did stepwise logistic regression modeling and came out with factors that influence risk of ultimate bad outcome, which included posterior location, size, and age. And actually, Bob did a very nice final analysis, a final model, where he's able to generate probability curves of bad outcome based on these various factors. So here's a 40-year-old with a 5 millimeter anterior communicating artery. Here's a 3D picture of this lesion. It turned out this patient was actually a physical therapist. He says, what's my risk of having significant deficit after one of these? Physical therapist had seen some of our finer work in the past and wanted to know that. But we calculated that out at about 1.8%. How did we do that? We took the data we had, and Bob came up with these risk analysis curves. This is the average risk, and it's plotted against age for a 5 millimeter unruptured lesion. And these are the upper and lower confidence intervals of that graph. Here's the risk of poor outcome for a larger anterior circulation lesion, 10 millimeters. And you can see as the size increases at any per age number, the risk goes up. Here's for a larger anterior circulation lesion. This is based on analysis of our data at the time with open surgery. We did the same thing for posterior circulation lesions because we were still operating on a number of basilar and posterior circulation lesions at the time. And the same type of stratification occurred. That is, for smaller lesions, the risk was lower. This graph shows a plot of both anterior and posterior circulation lesions stratified by size, the different lines, and then by age. And you can see by the time you're looking at a 70-year-old with a 15 millimeter posterior circulation lesion, you're looking at a projected risk of surgery running in a pretty high number. And this is right when we were turning to endovascular strategies for such lesions. This is just a woman, a smoker we operated, and it's a video I won't show you. It just shows that you can walk into the operating room on a Wednesday morning, have one of these things ruptured during surgery and have a struggle with it, but still have the patient do well. So when we look at patient treatment risks, we have patient-specific factors just like natural history risks, age, medical comorbidity, and lesion-specific factors of size, location, calcification, as you saw earlier today in lots of the videos, how they can increase risk of treatment and difficulty of treatment. And then location, local anatomy of the details. Are the parent vessels adherent to it? Are there perforators? And these influence our judgment as to how an aneurysm can be treated. So I'd like to now discuss that a little bit. So as with the natural history, there's stratification of treatment-related risks, and that highly specific treatment selection of surgical and endovascular therapy can be used based on patient and aneurysm-specific characteristics, and that treatment risk is not static, but changes as our specialty progresses. And there's a number of papers, as I've alluded, that discuss stratification of outcome of surgical treatment and endovascular treatment. But in each unruptured aneurysm that we encounter, we feel we can do an analysis that incorporates lesion and patient-specific factors. And we try to arrive at what we call a synergistic treatment of unruptured aneurysms. So I'll remind you that previous treatment of unruptured aneurysms really fell into reports that were either surgical or endovascular. And they were often couched in terms of clip versus coil or surgery versus endovascular. But true combined modality management was really lacking in the literature. Alexander and Reyna in 2009 looked at both unruptured and ruptured lesions and reported them in this fashion, but little else was in the literature. And I'll remind you that synergy is the interaction or cooperation of two or more organizations, substances, or other agents where the combined effect is greater than the sum. And that's what we look at now, really, with our treatment of unruptured aneurysms. So we looked at our current risk stratification in our current practice. And I practice with two other surgeons who do both endovascular and surgical work. We all work very much collaboratively. And we looked at our data over a 3-year interval, as you see here, of 658 patients with 553 patients, 658 lesions. And we would meet weekly to review unruptured aneurysms, and we would decide whether it would be better treated surgically or endovascularly. Most of the surgeries were clipping. And of the endovascular techniques, we use direct coiling, stent-assisted coiling, balloon-assisted coiling, or flow diversion. And we chose a treatment modality based on the predicted risk of that patient, and there was a significant selection bias. So during the same interval, as I mentioned earlier in my talk, there was 960 patients we evaluated with unruptured aneurysms that did not merit any treatment based on aneurysm size, patient comorbidities, or age. So there was a lot of patients we didn't treat. And we published the results of the treatments of this combined modality therapy in World Neurosurgery last year. This was a 2019 publication. We use that same logistic regression modeling that we used for open surgery. And you can see here again, majority of patients female. In terms of treatment, microsurgical clipping used in 38.2%, which some of the reviewers thought was a bit high, but in our hands, we felt it was reasonable. And a full 37%, almost 38% being treated with flow diversion. You can see the rest treated with coiling or stent-assisted coiling. And this is the size distribution of the patients treated and age, which is pretty similar to our surgical series from 2003 as we looked at it. And people ask these questions, so I show this is the percentage of procedures stratified by aneurysm size, both surgically and endovascularly. And remember, this is not surgery versus endovascular, it's surgery and endovascular. And you can see by size, when we got into the very large and giant, we often favored endovascular therapies. Those were many times for the giant paraclinoids that we now treat with flow diversion. And here's how the surgery or endovascular treatment broke down by location. And you can see a large number of the MCAs were clipped, and a large number of the ACAs were treated endovascularly, and that represents a heavy use of flow diversion. You can see the ACOMs kind of went one way or the other based on local anatomy and projected risk. Well, how did we do with this treatment? Based on the analysis on the final matter, we found that the risk was much less age influenced for endovascular therapy. In fact, almost straight lines were identified, or very slight slopes to these straight lines. And I won't drag you through all these details, except to say that both for the anterior and posterior circulation, that seemed to be the case. We had complications. You cannot treat patients without having complications. And you can see what we call non-neurologic complications, and realize this is for both surgical and endovascular lesions. So the pseudoaneurysms were obviously in the endovascular patients, as were the retroperitoneal hemorrhages. but the surgical site infection was in the surgical patients. But of this 658 lesions, we had 28 complications that were non-neurologic, and thankfully, none of those produced permanent morbidity. Not true with neurologic complications. With neurologic complications, you can see here we had a total of 38 out of this total number of patients, and we broke down what those were in terms of hemorrhagic, cranial nerve palsy being permanent or transient, and then combined neurologic and other complications, with a final rate of 38 patients with total complications, or 5.7% of this group. 1% were permanent and disabling. We didn't have any deaths, but we had 1% permanent and disabling complications, and almost 5% that were reversible or with an MRS, with an MRS 0 to 2. Well, we took these results and laid them out next to our surgical results. I realize it's a historical comparison with its inherent flaws, but when we did that, our surgical results are reported based on Glasgow outcome scale, so we couldn't lay them directly over it. But please notice that, remember, these complications were approaching a high double, in the double digits. The complications when using surgery and endovascular strategies combined run in the low single digits, and that makes a huge influence on your decision-making process. And I'll just finish by showing you this, which is from the UCAS data, from the Japanese data. We see that, I'll finish this section. I have one more little section to show, but you can project what the rupture rate is even for small aneurysms. And you can see that there is, based on binomial probability, and you can see that over 3 or 4 years, there is a risk of rupture that can be rivaled by the treatment-related risks if you can keep this in the 2 to 3% range. So if you're dealing with a young individual, we have discussions of treatment of even 5 and 6 or 3 and 4 millimeter lesions in certain situations. Admittedly, these are caveats, these are special situations, but it's there, and that runs. So our conclusion of this section is that high selection bias in this group did occur, but we feel that by using, and I feel most centers are using this now, a combination of endovascular and surgical strategies to maximize outcomes and minimize risks is really the best strategy. I'll close with a comment on screening. There are guidelines for screening, published guidelines in the American Heart Association in stroke. We helped author these. And in terms of screening, the current recommendation for unruptured aneurysms is 2 or more family members with an aneurysm or subarachnoid hemorrhage, or a history of autosomal dominant polycystic kidney disease, particularly with a family history. And then this was class 2A data, and where it was reasonable to screen patients with aortic coarctation of the aorta and primordial dwarfism. And the suggestion was to screen in young adulthood. Well, we wanted to look at one specific factor, and that is smoking. Smoking has been associated with aneurysmal subarachnoid hemorrhage and poor outcome. It's been suggested to play a role in aneurysmal development. And we conducted a study to look at the prevalence of aneurysms in smokers. And we wanted to make that the highest yield possible. So we looked in women who we knew had the highest incidence of unruptured aneurysms. So we conducted a case control study, and this has been accepted for publication, but not published yet. But we looked from a cohort of over 2,000 patients. We excluded any patients with polycystic kidney disease, connective tissue disorders, or family history. And we wanted to find what the prevalence of rupture of aneurysms was. And what we found that is in females between ages of 30 and 60 who are non-smokers, a prevalence of 1.9% was present. But when they were smokers, a prevalence of 19% was present. So that's 10 times the number. 1.9% is general population number. And we did a case control analysis, and we found that females that smoked cigarettes had an odds ratio of 5.8, females that were hypertension 3.8, and females that smoke and had hypertension 12.6 odds ratio. So based on this single center series, we're wondering, should the criteria for treatment change? And we now conducted a multi-center case-controlled study. It is in review, which shows the same exact thing, that the incidence in smokers who are women is higher, and it raises the issue whether these people should be screened. So in conclusion, younger patients, younger than 60, with lesions greater than 4 to 6 milliliters should be considered for treatment. The younger the patient, the stronger consideration for treatment. We feel that input from several physicians working together, neurology, radiology, neurovascular, neurosurgery, is extremely helpful, and we use that as our weekly conference. And at present, patients are evaluated on a case-by-case basis, trying to incorporate true morbidity of treatment balanced against best estimates of the natural history for that individual. In addition, the psychological and social factors are important, and final decisions made to treat unruptured aneurysms. And once a decision is made to treat a patient, the next decision is how to treat that patient. And that's based on your center's expertise in endovascular and surgical management and track record in running these statistics. I'll finish there, and thank you all for your attention.
Thank you very much, Dr. Ogilvy. Outstanding lecture. So we have a few questions from the public. So the first one is, what do you think are the indications for endovascular treatment of a MCA bifurcation aneurysm?
This is an evolving topic. As you can see in the analysis we did, it was before Webb hit the press, so we did not have the Webb device, so that wide-based MCA lesions were treated with surgery. Our track record on treating those is very good in terms of risk profile. However, we are using the Webb device and having, as others, a positive experience with it. The question might be couched, how will that change in the future? I don't know the answer to that. I think the way to follow that is to treat the patients endovascularly or surgically how you feel best. If it's maybe a little older patient, consider endovascular treatment, and then keep track of the results very carefully to see if our paradigm should shift to a more endovascular strategy. We also stent coil MCA aneurysms. As you can see in our experience, the majority work taken care of surgically. It doesn't mean it's right. It means that's what we've had success with. But I think that is one point, great question, where the paradigm may shift with time.
Okay, great. What do you think about surgery for a basilar bifurcation incidental aneurysm?
I love it, but unfortunately, the statistics run such that for smaller lesions, wide-based, it's still sometimes used. But again, the endovascular strategies that are being used today, lower risk, high efficacy, meaning the chance of obliteration is high. And we published a paper looking at, because that's a criticism of endovascular strategy, but we shouldn't just like the other things I showed you, that risk can be stratified in terms of the efficacy of treatment. And we published a paper in Stroke 2 years ago demonstrating that when you take into factors of how well an aneurysm is treated and how it is treated endovascularly, you can't quote a risk of recurrence of 20%, because in patients that are well treated with Raymond-Roy 1 occlusion, usually the recurrence rate is exceedingly low. If it's a poor occlusion, just coiled, wide-based, the recurrence rate is exceedingly high. So we use that type of analysis to help in the decision-making process here. Okay.
What is the role of aneurysm wall imaging to predict the risk of rupture?
Well, it's an evolving role. We, I think, like a number of groups, are working with MRI technology and other technologies to try to evaluate wall thickness. We would love to know, of course, when you encounter an unruptured aneurysm patient, you want to know, is this the one that's going to go on to hemorrhage, or is this the one you're going to find at autopsy in the 90-year-old who died of pneumonia in the nursing home? At present, there's no way to know that. I think wall technology, imaging, and pulsatility, and biology are the three ways that's going to evolve. And I love to see people working on that, because the more information we have, if we can get it with a scan, if we can get it less invasively, it can help counsel us and help counsel our patients as to whether they have the aneurysm that's never going to hemorrhage versus the one that's more likely to bleed.
Sure. In which case you choose to operate or do endovascular management of a 70-year-old patient or older with an unruptured aneurysm?
Certainly age influences our judgment significantly. And as you saw by those curves of our combined modality treatment, we think we've struck a recipe where age has become less of a factor in treatment. Not that it's not a factor, but I think that by and large, and there's a number of publications to back this up, the endovascular strategies fare better for patients over, and the criteria for what the over number is depends on which publication you look at, but it's usually pegged at 65, 60, or 70. So for those patients, we sometimes see an aneurysm and say, gee, this would be great to clip, but we can get it's got a narrow neck, we can get a very good occlusion endovascularly, and we opt for an endovascular strategy. I think if we stratified our patients by age and looked at how we treated them, the older a patient gets, the more, in fact, we did this at one point, the more we would favor an endovascular approach. But that same aneurysm in a 30-year-old, we might favor a surgical approach for durability.
Okay. In cases of a cavernous carotid artery aneurysm with mass effect and oculomotor nerve palsy in a healthy middle-aged patient, which is the gold standard of treatment?
Well, I don't know if there is a gold standard of treatment. I used to do probably 10 bypasses a year for that exact lesion. We'd do a bypass, we'd occlude the carotid, we'd replace the carotid with a large vein bypass, as you saw Dr. Charbel and Dr. Lawton, from the carotid in the neck to the middle cerebral in the head. I haven't done one of those bypasses in a number of years because of flow diversion. And our efficacy, which we published pretty extensively, as have others. In fact, we put out a supplement to Neurosurgery at the beginning of the year in January. The efficacies for those large and giant lesions runs around 90%, with complication rates that are low, in the low single digits. So it's really hard to beat that. You have to live through the edema of the aneurysm thrombosing, and it's shrinking down over time. But when you do that, the patients get better over time. And as many of you know who follow these patients now for 7, 8, 9, 10 years, 7 or 8, 9 years, the actual mass of the aneurysm shrinks away with flow diversion if it's worked, if it's treated the lesion, which was something of a surprise to me when I first saw it.
Okay, is aspirin a protective or a risk factor for an aneurysm rupture?
Great question. Who's doing research on this? I can't remember his name. He's a great guy. There's actually been a couple of studies, one study initiated to give patients with unruptured aneurysms aspirin to see if it reduces the risk of rupture. The concept is that aneurysms form because of some type of inflammation. And I think that may be why smoking contributes so much to aneurysm formation and rupture, is that it's an inflammatory for the wall of the vessel. Whether aspirin is protective or not against growth, against rupture, or against aneurysm formation is still an open question. The one study I know that was done, there weren't enough patients and it was not conclusive at all. Okay. One thing that's clear is that when patients have unruptured aneurysms, you get a call all the time from the primary care physicians, we shouldn't anticoagulate these patients, we shouldn't use aspirin. There's very little data to support that. If an aneurysm ruptures and they're on Coumadin, the risk of that rupture is probably higher. There's really been only 2 papers that have really looked at that, but it's not ironclad. And if they need that Coumadin for a CHAD4 or a CHAD3 cardiac issue, we recommend anticoagulation. And same with aspirin, I'm pretty liberal with that.
Okay. Do you think the neurovascular group experience should lead the decision on how to treat an aneurysm?
Do I think the neurovascular? Yeah, I mean, I think that patients with an aneurysm should be seen by someone who can go through what I just went through. And at least in New England, where I practice, many of these office visits are an hour long because the patients are understanding of a lot of the information and want to know the balance between risk of treatment and risk of leaving it alone. And many of them, if you explain the rationale as to why you're not treating their aneurysm, it makes sense and they're okay with it. They're fine with it. But I think that at some point, neurovascular consultation is of value. Now, there are places around the country, around the world, where people say, below 3 millimeters, I just don't want to see that patient. The problem is the primary care physician sometimes has difficulty explaining the kind of stratification I just went through. And some of them aren't as savvy to it. The fact that they know aneurysms need some type of attention, even if it's just verbal, is good.
Okay. And the last question, will you treat less than 3 millimeter anterior circulation aneurysm in a young adult?
So this comes up from time to time. If you meet a 20, 22, 25-year-old person, particularly a woman, they want to have children. They want to be, and of course the obstetricians want a letter stating you guarantee nothing will happen during childbirth, which no one can write. But we have treated such patients. It depends on what the lesion looks like, the exact location, the morphology, and other health of the patient. If it's a perfectly healthy 30-year-old with a 3 or 4 millimeter unruptured carotid or MCA aneurysm, we have treated that lesion. But it's a big discussion, and it is a decision point, and it's not always the same in two individuals, even of the same age.
Okay, thank you very much, Dr. Ogilvy. On behalf of CN, I'd like to thank you again. We're really grateful and honored for your participation in the 2020 IWBNC, and you're more than welcome to stay tuned to watch more lectures from other speakers. In a few minutes, we'll have Dr. Juan Fernandez Miranda doing his lecture, Stepwise Anatomically Based Resection of the Medial Wall of the Cavernous Sinus, a game-changing technique in pituitary surgery. Okay, thank you very much, Dr. Ogilvy.
Great symposium. Thanks very much.
Thank you.